almost 15 years ago, or almost 20 years ago now, this group led by Palisano came up with this really great scale that everybody should use called the Gross Motor Function Classification System. And it's great because you don't even have to examine a patient to use it. You can ask the parents what their child's functional capabilities are, and you can determine their GMFCS level. And it was developed, validated against something called the Gross Motor Function Measure, which is a series of different tests of rolling and sitting and climbing stairs. But that test takes about an hour and a half to do, and it's just not useful in a clinical setting. You're not going to get orthopedic surgeons and neurologists and physical medicine docs and all these people to use it because it takes too much time. So the GMFCS, because it's so validated, can really give us an instantaneous snapshot of the functional level of these children. So what I like to tell people is, if you're normal, you're not on this scale, you're a 0. So somebody who's a 1 is not completely normal, but they walk around pretty much unrestricted, and you really only see issues when you put them up against their able-bodied peers on the playground playing sports and things like that. But they can climb up and down stairs. They can climb up and down stairs without holding onto a railing, carrying an object. And that's really, for a really high-functioning 2 versus a 1, that is the delineating functional skill, is their ability to climb up and down stairs without using a railing. And then somebody who's a 2 is somebody like me. So if I'm in a relaxed environment without you guys watching me in my home, I can walk around without an assistive device. I might have fingerprints on my walls because every once in a while I grab onto the wall for balance. But I can walk, I can take independent steps, and I can get around. But in stressful environments, on rough terrain, if there's a curb on the ground, I'll be on the ground. And so I use a cane, or sometimes I have to hold on to Reuben. But you can take independent steps for a meaningful difference, not just like 5 independent steps. And then somebody who's a 3 cannot walk without an assistive device, but they can walk with a handheld assistive device, whether it's a reverse walker that they can get in and out of, or canes, or a single cane. Whereas somebody who's a 4 really needs more. They might be able to take a few steps with that type of assistive device, but they really use a wheelchair mostly to get around, or they use a gait trainer, which is much more supportive, that supports them at the trunk. And then but if a level 4 patient has the right technology, they could actually function independently, maybe with somebody coming in and helping them get dressed and things like that, but they can use available assistive technology to live independently. Whereas somebody who's a 5 cannot survive without human assistance, even with all available assistive technology. They have trouble holding up their head, they have trouble sitting independently. So why do I care about the levels? Well, now that these GMFCS levels have been around long enough, and because I showed you the ones for age 6 and above, but they've backtracked it now where you can actually do a pretty good job of guessing even at age 2 to 4. We know the correlations between your likelihood of having other complications and problems just based on your GMFCS level, not taking into account dystonia or anything like that. Based on your GMFCS level, if you are non-ambulatory, you're much more likely to have hip dysplasia and hip abnormalities requiring surgery. You're much more likely to get sick. You're much more likely to have epilepsy, visual problems. So it gives us a bunch of red flags. So we know if you've got a patient who's non-ambulatory, you've got to really pay extra special attention. And you also have to fight harder to get them into social activities and social participation in education. So how do we help them? Well, what I like to tell families, and this actually pertains to everybody, to you too, you can just carve it out for orthotics, is you always start with the basics. You always go back to the basics. It looks complicated, kids are complicated. You always go back to the basics. Second thing is, no matter who they are, they've got to stand up, whether they're GMFCS 4 or 5 or whether they're 1, 2, or 3. They have to stand up and they have to get moving. And the third thing is, and this is an important thing to tell families, because families a lot of times think, oh, you're putting an orthotic on, that means that they're never gonna get stronger they're cheating, or you're giving them an assistive device. It's not cheating. You're using assistive technology to give them full participation in their environment, and if you use the right assistive technology, they'll actually get stronger in all the other muscles and all the other things, because otherwise they fatigue so rapidly that they go into a pattern, or they just collapse, or they just end up sitting all the time because no, they're not wearing orthotics and they're not using a walker, but guess what? They're sitting all the time, and the only time they walk independently is for the 5 or 10 steps they take. So these are really the basics. When I talk about with always starting the basics, and again, you're going to say, well, how the heck does nutrition and sleep apply to me? I'm an orthotist. Well, these are the basics, and I have a list of things that I tell parents they have to worry about before I even get to walking, even though walking is the #1 thing that parents want to know about. So the top 2 things after making sure a kid is breathing and their heart is beating, which is a given, the top 2 things is they have to have adequate nutrition and they have to have sleep. So if you don't have enough gas in the tank and you don't have enough subcutaneous tissue and muscle and things like that, you're not going to be able to use all these orthotics. They're not going to matter. And you're going to get more pressure points and skin breakdown and things like that. So if again, you might be the only person paying attention to this. The kid comes in, they look really thin, they're not, they're sick. You say, when's the last time you saw a dietitian or somebody or saw the doctor about the weight, your child's weight? It's concerning. Because nobody might have even said anything to them. And you look at me like, oh, that's ridiculous. You're seeing all these doctors. Trust me. I'm an atypical neurologist. I do this comprehensive look at patients, and I talk about diet. That's like the #1 thing I talk about. It's because nobody minds the shop. All these kids are seeing all these different people, and they're going and seeing them for 10 minutes, and they're all doing their little piece. There's all these big holes missing in their management. So you might be the only one that pays attention, but they've got to be eating. The next thing is they've got to sleep. I don't care about before you do anything else. If you don't sleep, you don't learn. You lay down memory during sleep. If you don't sleep, you don't grow. If you don't sleep and you're a kid with CP, you're much more likely to have, first of all, you're much more likely to have seizures anyway. But that is how we make people have seizures for EEGs, is we sleep deprive them. And if you're not sleeping and the doctor prescribes all these knee stretching splints and ankle stretching splints and tells you to go to bed in them, forget it, because they've got to sleep. It's more important for them to sleep than it is to stretch out their contracted muscles. And I want their muscles to be stretched out. But if you got a kid, ask the kid, are they sleeping at night? If they're not sleeping at night and you're going to put them in a stretching splint, you better come up with a plan to do it during the day, because don't take away their sleep. And you tell them when you give them the stretching splint, okay, your kid sleeps well, I'm going to put them in the stretching splint. If they stop sleeping, call me up. We've got to fix that, because you don't want to be the guy or the woman, the girl, that screwed up a kid's sleep, because it will harm them. So you've got to ask about sleep. Vision and hearing is important. What I like to say for orthotists is it's important that you see what's going on and you see the best orthotics and you look at the whole picture. And then communication. I mean, we work really hard to get kids to communicate. We use assistive technology, augmentative communication. But in this audience, the really important thing is you've got to communicate with families, which you probably do really well, but you've got to communicate with the doctors. Even if you don't want to, even if you've got doctors that are Texas cowboys that are like, you're going to do it my way. You've got to figure out a way to communicate with them, because that's the only way you're going to be able to take care of your patients. And if you can't find a doctor that will talk to you about your patients, send your patients to me. I will talk to you. Ask Suzanne. Ask Keith. But it's really important, because it's a team approach, and otherwise we're just wasting people's time and money. And I can't even tell you how many kids I come in that have orthotics that just sit in the closet, especially stretching splints. And part of it's because of a lack of communication of why they need to wear them, and they were hurting and the parents just threw them in the closet instead of telling somebody. So I'm not going to go over everything on this slide, because we're here to talk about mobility and orthotics, but again, I'll point you back to this slide and how complex it is, and all these different things that we address with the overall goal of achieving maximal independence and participation. So one really big thing is in terms of mobility, if they can't walk or do anything else, you absolutely have to stand them up, because standing them up helps their hips develop. But more importantly, standing them up is the single best way to protect their bones from breaking. There is no drug on the planet that will help bone density the way that standing helps bone density. And when kids are growing, their bones are much more metabolically active, and that's when they're laying down bone. So they absolutely have to stand up. And in addition, a good standing frame can actually also help stretch out your hamstrings and get things in much better alignment. So what do they need in order to stand up? They've got to have good feet. And again, it doesn't matter. You can't just look at it. You have to treat the kids in the wheelchairs like you treat the other kids, because they have to stand up. And if you know they have to stand up on feet that don't hurt. So they have to have a good-looking foot. You don't want to have kids with feet like the pictures that Keith had showed you. You got to go to the mat, even if it means putting them in plantar flexion or whatever, to give them the best possible foot that doesn't hurt, because that's more important than having an ankle range of 90 degrees or better of dorsiflexion range. And it also, if you give them a good base of support, they can participate in other activities. They can walk, but they can also do things like play sports. And when you're talking about orthotics, and this is a very recent patient that I saw, his AFO, this is his AFO, you have to make sure they fit. Nobody should have an orthotic that looks like that. And the reason why this kid looks like that isn't because the orthotist isn't good, and it isn't because they don't know what they're doing, and it's not because the orthotics people don't know how to make an orthotic. It's because they didn't get enough people there to hold this kid and to help get him relaxed because of his dystonia, to get his foot in the best position, which turns out to be about 5 degrees of plantar flexion so he doesn't collapse into ankle valgus, but he also has athetosis and dystonia. And when he even thinks about relaxing because you're trying to, or sees you coming out in place, and so in a split second, it can turn into that even while you think you're holding him in a good position. So it took 3 of us, the orthotist, me, and a therapist, to hold this, to help hold this kid while the mom's trying to get him to relax and massaging his back to try to get his foot in a good position. I tried to get it back in time to show you the finished product, but I had to come and do this and we couldn't get it delivered in time. So please make sure that you have your foot in a good position, even if they're not in 90 degrees. And then the next big thing is to get them up moving, and moving doesn't have to be boring physical therapy. In fact, it's better if it's sports and things like that. And I was really blessed to be in St. Louis for many reasons, but one of the big reasons was it's where I got to learn to play sports for the first time ever. I was summarily excused from sports when I was growing up. And then I got to bring sports to all these kids, and we started with swimming and martial arts, and then this was our basketball program. And I'm in there somewhere playing basketball, but I never got to play basketball when I was growing up because athletics would make your spasticity worse, so that was the dogma. But then we got an endowment from the Hatfields, and now we have this big intensive sports program where kids come 5 days a week, 6 to 7 hours a day, and play sports. And it's really life-changing, and they work harder in therapy, they start to set goals for themselves, and it really does change lives. So get them moving. And then when you talk about mobility, you break mobility down into different things. We talked about tone, we talked about flexibility and biomechanics. Motor control is the hardest thing to actually fix, because motor control primarily involves, even if you help the dystonia, and even if you help the spasticity, motor control involves the actual neurons that are damaged by the injury, where they can't make the signals for things to come down. And so a lot of times that's really hard to change and to teach patients to recruit more muscle and things like that. But you can change all these other things, and patients can learn new motor tasks. Strength is one of the easiest things to change. Balance just depends on what's causing the balance problems, but as you've already seen, you can change a kid's balance instantaneously by putting them in the right orthotics. So this is just a video to show you the value of strength training. So this is a teenager that came to me at age 12, and adolescence is, I talk about adolescents walking this tightrope a lot of times. They go through a rapid growth phase and they can fall off the tightrope and either end up in a wheelchair or continue walking because if their muscles don't keep up with the spasticity and everything. But this kid, we basically bribed to do strength training 3 times a week on a leg press, and then to do physical fitness. And 4 years later, and we gave him a music CD every month for filling out this chart of all the things that he did. And those are the only 2 things he did. We didn't add any more surgeries, we didn't add any more medication. You could see the muscle bulk and everything. And PTs dropped their jaws at this, because this is all not from physical therapy. He got on a treadmill and he did strength training, and that was it. And sometimes you have patients like that, and that's all they need. He does have orthotics. But he had orthotics before. So it really was the strength training component was the big deal. So patients come in and they want you to do something about the walking on the toes or the spasticity or things like that. But really, the foundation for all these kids is hard work. You have to learn new motor skills, just like you have to learn everything. And so PT, OT, speech therapy, those are the foundations, and everything else we have are tools in the toolbox to help the hard work be more effective. And everything has a dose, and everything there's the right tool for the right time at the right dose, and you have to have a goal. And now people are really starting to go back and not just they examine SDR. SDR got a lot of criticism, and examine SDR, but also look at therapies and say, is all this therapy really working? And as it turns out, we are starting to make headways in terms of exactly what type of therapy you should be doing and which muscles you should be strengthening. And I don't have time to go through all that, but one really cool thing is you can take somebody who's GMFCS 4 and 5, like Chloe, who cannot walk independently. She can take steps in a gait trainer, but if you go to something more recently with robotics, she loves this, and she's walking on a treadmill, but the way the technology is going, there will be over-the-ground robots, carbon fiber robots. You as orthotists could be prescribing robots. So I could put it on and go race you down the hall. And I think that's very exciting. And so that's even another reason that I tell patients in wheelchairs, you still have to keep your feet in good shape because you're going to need them someday for standing and walking. So when we talk about treating tone, there's all kinds of things we can do to treat tone, but we don't have a lot that are extremely effective. SDR is the most effective thing for treating spasticity in the right patient. Casting, splinting, bracing, stretching, those are all treating the effects of too much tone, but not really treating the spasticity itself. Botulinum toxin, which blocks the presynaptic release of acetylcholine from the nerve terminal to the muscle, basically partially paralyzes muscles temporarily so that you can get a better stretch and so that you can block some of the motion of opposing muscles to get the other opposing muscles to work, to get the agonist muscles to work better by reducing the pull of the opposing muscles. There is no oral medication that has been FDA approved, including baclofen, which has been around for over 30 years, for use in children with cerebral palsy. Botulinum toxin, which is now FDA approved for upper extremity spasticity use in adults with CP, is not yet approved in children, but it is really the only medication, albeit injectable, that has good level A evidence for its ability to reduce spasticity. So we have a lot more work to do. And Keith already showed an example of SDR, but this is one of our little guys from St. Louis. You can see he's got that gait that Keith was talking about with his knees bent up on his toes. And then 9 months after SDR, he's walking much better. And that's for the right patient, and again, it's got to be the right patient. For the right patient, there's nothing that can touch it. And the right patient is somebody who already walks independently, has significant lower extremity spasticity, good preserved strength, and is highly motivated. We talked about intrathecal baclofen pump. You saw this young lady before. I'll just show you the after. Well, I can show you both at the same time. But the intrathecal baclofen pump, which is a pump filled with baclofen, and it's a surgery that puts the pump under the skin and the catheter goes into the cerebrospinal fluid and the spinal cord, is an effective way in patients that have quadriplegia and severe spasticity and dystonia. And in this case, it allowed her to use her hands functionally for the first time and bring her hands to midline. So it has complications, but it's a very effective treatment for the right patient. The patients that get pumps aren't usually patients that are walking. And a lot of times when you put pumps in patients, they'll stop walking. So this is just a schematic to kind of break down the different things in terms of tone and hypertonia, with the idea that if we take spasticity in the middle, there's some oral medications that we use, oftentimes a cocktail. Botulinum toxin is really a very powerful tool, but it wears off. SDR I've already talked about, and the intrathecal baclofen pump. A lot of people try to treat spasticity by doing lengthenings, and there's a lot of rush to go off and do SPMLs and perks and things like that, which can be very valuable procedures, but timing is key because you're really treating the end organ problem. You're not really treating the primary spasticity itself, and kids will outgrow lengthening procedures, and more importantly, the worst thing that can happen is to be over-lengthened, both at the knee and the ankle. Orthotics, I put a maybe there because if somebody has pure spasticity and doesn't have stiffness and doesn't have contractures, be very careful about which orthotic you put them in because you can actually do harm with certain orthotics. If you take away somebody's spastic catch because they're walking on their toes and you put them in a hinged DAFO with free dorsal flexion and block their ability to plantar flex, and all of a sudden they start overstretching their soleus, which is a really powerful anti-crouch muscle, you can get into trouble. So you just have to really be watching. Whereas somebody with contractures, you can try serial casting, you can try orthotics, you can try stretching splints, but if they have a strong contracture, they really need to go to the orthopedic surgeon. And stiffness, it really depends on what's causing the stiffness. And again, most disorders are mixed. And one big thing I have to say about dystonia is if you have a patient with dystonia, it doesn't just have to be wiggly athletoid dystonia, the dystonic posturing in their legs and their feet. One big thing is if you put them in a rigid AFO, they will not be able to walk. They literally will not wear them and they will not be able to walk, even if they can walk without them. Keith has already shown, this is another example of a patient where instantaneously he went from needing help to walk to walking independently just by putting him in an AFO. And I'm really proud of Sean because he actually broke his leg 3 years ago because he was wearing a knee immobilizer to stretch his legs, and he decided to get up to go to the bathroom, to go to the refrigerator to get something, and didn't take it off, turned around funny and fell down and broke his leg, his femur. So that's another important thing. You give somebody an immobilizer and you get some kid that's really gung-ho, just warn them, don't get up and walk in this, which is a valuable lesson to learn because they can get hurt. But the FlexiSport is what he's wearing, and he's got a lot of dystonia, but that FlexiSport made it possible for him to go from not walking independently to walking independently. Again, we talk about tools, there's all kinds of tools, and there's not usually one right answer for everything. So you need the right tool for the right goal, at the right dose, at the right time. And all interventions have side effects, including orthotics. You put an orthotic on somebody, they're going to get weak in the muscle under the orthotic, 9.5 times out of 10. But doing nothing usually has more side effects. And this is to leave you with my favorite Dafos. And in fact, the FlexiSport is probably the brace that I prescribe the most often, period, just because it allows motion into dorsiflexion. You're not at risk for having somebody go into crouch and over lengthen. And the plastic moves, and it's not rigid. I just remind you again of the basics. These are my kids from St. Louis and around the country, some of them. We always can give patients hope. It's never hopeless until you run out of ideas, and if you don't have all the ideas, you can find somebody else that has more ideas. And these are the Sutherlands from our brand new, they came all the way down from Missouri to visit our brand new clinic at 1 CP Place. Thank you very much.